Good afternoon, everybody. Welcome to another interesting session here at EuroPCR. This one is addressing current and upcoming needs in all heart valve diseases with the latest procedural and device innovations. It's sponsored by Edwards. And we have a real excellent faculty around that I would like to introduce just shortly. I'm co-chairing the session here with Prendergast, who's going to give his introduction soon from now. My name is Treede. We're here with Dominique Betex, Paulo Denti, Karel Koch, George Nickenik, Fabian Niedlisbach, John Webb, and Elad Eschers, our React to PCR moderator. And this, again, should stimulate you to ask your questions through PCR React, because only then we can answer the questions from the panel. So, Bernard, can you start, please?
So thank you very much, Andrik, and welcome all to this session. And it's a great honour to be here, particularly amongst such a star-studded faculty. What we hope to encompass in this session is to address the diversity of heart valve disease. In 2018, we have moved way beyond the aortic valve and way beyond transcatheter aortic valve implantation. And that brings with it new innovations, but also new challenges. We all recognise that heart valve disease is common, and these data from the community screening study using echocardiography in Oxford, UK, demonstrated that heart valve disease, even in asymptomatic patients, was far more common than we would anticipate. You will see here in these data that aortic stenosis, mitral and regurgitation, and tricuspid regurgitation affect a small, but in terms of absolute numbers, large number of patients who are fit and well in our communities. And furthermore, that this disease is clinically silent and currently not recognized by conventional healthcare pathways. And if we factor in that the population is aging very rapidly in virtually all developed countries, we can project that the amount of valvular heart disease is going to double worldwide in the next 25 years. And this is going to represent a growing challenge for interventional cardiologists, general cardiologists, and family physicians. Here is the status quo in my own institution, St. Thomas's Hospital in London, where we are currently performing just short of 500 surgical valve procedures per annum, 280 transcatheter aortic valve procedures with a short length of stay, but a far too long waiting list on account of our problems with capacity, and our early inroads into transcatheter mitral and tricuspid valve procedures. And reflecting the growing demands on our service, we anticipate that even within the next 2 or 3 years, our capacity to undertake these procedures will need to grow considerably. It is likely that the number of surgical valve interventions will fall, and it is certain that the number of transcatheter aortic valve implantations will increase by a further 30 to 50%. In doing so, we hope that we will match demand, but in doing so, we will need to use our resources even more efficiently to enable us to match that demand in a clinically appropriate fashion. We also hope that based upon current developments in innovation and emerging evidence, that our mitral and tricuspid valve programs will grow significantly, although the extent of that growth will be determined by the evidence and the available finance. So we recognize that we have been and remain on a transcatheter heart valve journey which began 15 years ago, but which has accelerated very rapidly, particularly in the last 5 years, such that TAVI is now a routine day-in, day-out procedure in our cath lab, where patients' expectations are of a very low-risk procedure with very rapid hospital discharge. And I think the next phase of our challenge will be to match those demands in terms of the delivery of our results, and to do so in a cost-effective, efficient manner. So reflecting this agenda, the objectives for this session are to gain some appreciation of the depth of the challenge and what these challenges will be, both logistically and financially, and how we are able to deliver these treatments to our patients in an increasingly constrained healthcare environment. To learn how the innovations in transcatheter technologies will adapt and contribute to make our daily work even simpler and more efficient, and hopefully improve our ability to offer cost-effective solutions to healthcare purchasers for our patients. And therefore, over the next 90 minutes or so, we will be taking a whirlwind tour through the current available armory of transcatheter valve technologies appropriate for the aortic valve, but also extending the experience and extending the evidence into the mitral and tricuspid arenas. So I very much look forward to the session. We hope to engage with you in a regular fashion between the presentations, and we very much look forward to your questions. Thank you very much.
Yeah, thank you, Bernard, for this really thoughtful introduction. We now start with John Webb from Vancouver, who speaks about expanding the treatment options for patients with severe aortic stenosis by transcatheter procedures of the future. John, please.
Thank you very much. Let's see. How do I move on to my own slides? Just keep on pushing the button, perhaps? Escape. Yes, okay, good, that works. Although I haven't really escaped at all. Transcatheter procedures of the future, expanding the treatment options for patients with severe aortic stenosis. My disclosure, I work with Edwards, no surprise. 30-day mortality with transcatheter valve procedures, transcatheter aortic valve replacement is falling just very dramatically. We've seen early mortalities of 6% in our early partner trials down to routinely 1.1%, 0.9% analyses of patients with intermediate risk aortic valve disease. Stroke rates continue to fall dramatically as well, with here rates down to 1.4% in the Partner 2 high-risk trial. And we know that these trial outcomes are reflected in real-world outcomes as well, as presented at this study here on the left. You can see all-cause mortality in the SAPIEN 3 intermediate risk trial, 0.9%. In continued access in North America, as part of that trial where it wound up, 0.9%, and in the TVT registry with 2,000 patients in the propensity matched analysis, 0.8% as well. Similarly, the stroke rates around 2% in the trial, in continued access in North America, and in the TVT registry in North America. So it is real. Mortality is falling very dramatically, even in intermediate risk patients, where we can arguably do better than surgery can in perhaps low-risk patients. And we know that vascular complications are falling dramatically as well. As sheath size falls, we screen patients better, and physicians get better at doing the procedure. Here are 4.2% in the EU SAPIEN 3 trial that we were part of. With newer valves, leaks are falling dramatically. This is no longer the major problem that it was in the early days. Here in this particular evaluation, similarly other evaluations with the SAPIEN 3 and some other newer valves as well, 0.1% incidence of severe leaks. So that's 1 in 1,000 patients. It's still an issue, but not so much anymore. We now have pretty convincing evidence of durability, albeit less than some of the surgical valves, more than others. This is one of our early patients who's now out to 11 years after transcatheter valve implantation, had a transapical equine pericardial valve. There she is 10 years after the implant, mean gradient 11 millimeters of mercury with the 23 valve, still pretty good, and just mild aortic insufficiency. And we're going to have more and more anecdotal reports like this of late survival with transcatheter valves. We await long-term follow-up, but it looks like it's going to be favorable. Now, one of the problems we have is we still have unexpected problems with this procedure. In North America, most of these procedures are still performed with general anesthetic and very prolonged hospital stay. Here's an example of one patient, 85 years old, traumatic insertion of a urinary catheter with prolonged anesthesia. TAVR was very successful. Gross hematuria, bladder irrigation, blood transfusions, urosepsis, respiratory failure, pneumonia, died on post-op day 14. Why did he die? Because of the Foley, because of the general anesthetic? It's not clear, but the TAVI went well. But we need to do better. We need to avoid unnecessary interventions, and we need to have standardized clinical pathways. And I think I'd really stress the point of standardized clinical pathways. Everybody can do these procedures without an anesthetist in the room. They can do them without Foleys, without interventions, but I think standardization is the key to getting really good outcomes. In our program, in our one hospital and then our second hospital, and now we have 4 and 5 hospitals in the British Columbia program, we've dramatically reduced our use of general anesthetic. Most patients now are treated with local anesthesia, which is the default. Urinary catheters have been discontinued gradually and then now entirely. And we've moved many of our procedures from a hybrid operating room to cath labs. And in fact, most procedures are now done in standard cath labs. I think one thing that's really fundamental to moving patients through the system and doing higher volume and many patients in a day is having educated patients. And we have multiple avenues of doing this. There's a lot of nursing teaching, but here's 3 of our different publications. One describing the procedure, one talking about how you're having it today, and another one saying, well, you've had the procedure, now it's time to go home, and here's your instructions. So when people come in, they know they're going to come in the morning, they're going to have the procedure, they're going to be up walking by that evening, and they're going to be home tomorrow. Somebody's coming to get them tomorrow, and they have somebody staying with them as well. The nursing practice needs to be dramatically standardized. It used to be that we would go by and find a patient in the CCU or ICU and find out the patient hadn't been mobilized in 2 days. People were afraid to take lines out. Now it's cut and dried. Lines out at 4 hours, unless we tick a box that says 6 hours. Mobilized by 4 hours after that. Mobilized up in the morning after breakfast. Home by noon the next day. If the patient diverges from that pathway, there has to be a good reason. And similarly, the physician's orders are similar and go along with this. We have 2-page pre-printed physician's orders that are really the same for aortic, mitral, pulmonary, and tricuspid valve disease, just a few extra check boxes and so on. But it's all very standard. There are pathways, just like a factory. People have a route to go, and if they can diverge if need be, but most people follow the pathway. We have criteria-driven discharge, and I think this is really critical to getting patients out of hospital. This happens even if the cases are done on the Friday. The patients are mobilized on Saturday. They go home on Saturday afternoon. Here's an example of one of our patients. I don't know if the audio is playing, but it doesn't matter. But this is a 96-year-old physician. 3 hours post-TAVI, I walked into the room. He's laughing with the nurses. The nurses say, tell him what TAVI means. And I started to say transcatheter aortic valve implantation. He says, no, it means totally awesome valve implantation. And this is really part of my point is it's the patient experience. And patients come in, they have a procedure.